So what the Janeway lab's shown is that this enzyme complex, this process, is lost in paediatric and other wild type cysts compared with KIT. It's not, generally speaking, because of mutations in the subcomponents of this enzyme, which is what we thought it would be, because that's what it is in one of the syndromes. But no deletions, no mutations. So what does it mean? Well, I think, and I was interested to read a review on paediatric GIST from the group in the States, which sort of encouraged me to think along these lines, and that is that if you create an environment in the tumour that's a bit like hypoxia, low oxygen, because the glycolysis doesn't need oxygen, and cancer cells, first of all, cancers tend to outstrip their blood supply, and so the centre of a cancer will tend to be low in oxygen, so it's going to need to have a mechanism that generates energy without oxygen, number one. Number two, this environment tends to stimulate the growth of new blood vessels, and that's what cancers have to do if they're going to invade the adjacent tissue where they're growing. But there's probably an even more fundamental thing. Mitochondria, in addition to generating energy, are crucial to the process by which cells die. Now, we have literally, probably, certainly thousands, possibly millions of cells in our body dying every day. And that's the blood cells that we generate all the time, and they do their job and they die. If they didn't, we'd have leukemia. And the same is true for the cells that line the gut, that line the airways in the lungs. They are produced all the time, and they do their job and they're shed, like skin. Common cancers, of course, arise from tissues like that are dividing all the time, and that's probably why they're commoner than sarcomas that arise from tissues that aren't dividing all the time. So mitochondria play a crucial role in cell death. The mechanism of cell death we call apoptosis. Cancer cells don't want that. So it's beneficial to cancer cells to get rid of mitochondria. So cancer cells tend to have fewer mitochondria, and this may be why. Now the problem at the moment is, okay, so we're learning about what's driving paediatric and wild-type GIST, that it's a loss of this crucial enzyme, but we don't know why. And it may be that it's at the level of control of gene expression. So our genes, most of our genes probably at any one time in any individual cell are switched off. Any particular cell in the body has a specialised function. Could be a muscle cell, a nerve cell, a brain cell. They do certain things. They don't need all of the proteins that the cell could make. They only need a few of them. The rest of those genes are switched off. And so there's a standard mechanism by which that happens. Unfortunately, while that's necessary, cancer cells can subvert that, and they can switch off genes that we want to be there. Equally, they can switch genes on that we don't want to be there. And it may be that if the loss of this process is controlled by one of these gene-modifying processes, that we will find a way in the future of switching it on again, because we do have methyltransferase inhibitors, histone deacetylase inhibitors, drugs that have activity in cancer, and it may be that trials of one of these types of drug will prove useful in this most resistant group of patients with GIST. So just to conclude, adjuvant therapy is looking more promising than we expected, and we have to wait for the final reports and publications from the Scandinavian trial, but it does look as if a survival advantage is possible, and who knows, maybe 5 years treatment might be better than 3 years treatment, although I'm not sure we're going to see a 1,000-patient trial testing that. Pharmacokinetics remains important, and we need to somehow refocus our energy on finding out which patients actually need a bigger dose and can justify a bigger dose based on these data. And as I say, the problem at the moment is we don't really have a reliable threshold. I don't think we can necessarily say that the threshold published by George Dimitri is absolutely the right one for all populations. Depends how fit they are, depends on the tumour, depends when you test. For resistant mutations, I think we're going to need combinations. I hope the HSP90 inhibitors will provide a lead, but other combinations of other signalling inhibitors with imatinib are undoubtedly being tested as we speak, and we hope that that's going to lead to novel treatments which will be less likely to lead to resistance developing, and may perhaps allow us actually to kill all the GIST cells, which at the moment we can't. And so finally, I think further study of the wild-type paediatric group is teaching us something really fundamental about cancer, and while it doesn't immediately lead to a treatment for these patients which is specific to what is driving those cells, it may do, and I think that there's some ways in which we can think about how that might happen. And I'll finish there. Thank you.